Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is ART treatment failure in adults and adolescents, when and what to switch. And the speaker is Dr. Rajeeb Day. Dr. Rajeeb Day is working as a technical specialist public health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Good afternoon, everybody. I hope pretest is done. So I'm going directly to the topic. So today's session, second line ART failure, first line ART failure in adult and adolescent, and when to switch and what to switch. This is basically as a part of national guideline dissemination was taken long back by Dr. Rivari and Dr. Anwar. So today's session is basically a recapitulation of that. So in today's session, we are going to know what are the different responses that are that we expect after starting a patient on antiretroviral therapy, and when and how a patient fails on a particular ART regimen, and what are the importance of viral load testing and its relationship with adherence, drug adherence, and then treatment failure to first line ART and second line ART, and what to start as what options we have in the second line ART and in the third line ART. And thereafter, we'll discuss a little bit about drug-drug interaction with the key ARV drugs. Now, to know the HIV treatment failure, we need to know what kind of medicine, what kind of antiretroviral drugs act on which cycle of the HIV life cycle within the human host cells. So first, based on the trophism of the HIV virus, either they get attached to the CCR5 receptors on the surface of the CD4 cells of the host. And these are done, this is primarily attached by the M-trophic virus, while the T-trophic virus gets attracted towards the CXCR4 receptor on the CD4 cell surface. Now, once they get bound to these receptors, they get gradually goes inside, penetrates the cell surface into the host cell cytoplasm. Now, if we can develop some drugs that can block the attachment of the virus with the CCR5 or CXCR4 receptors, then the penetration of the virus can be prevented. And the drugs that were developed in this way were Meraviroc, which blocks the CCR5 receptors, while enfuviretide blocks the CXCR4 receptors. But if we fail to do so, the virus enters the cell cytoplasm, where the HIV RNA, viral RNA, is released along with the reverse transcriptase enzyme into the cytoplasm. This reverse transcriptase acts on the viral RNA to convert it into viral DNA. Now, if we can prevent with some medicine this step, that is reverse transcriptase, then we can also prevent the further progression of the HIV life cycle within the host cell. And the drugs that were developed were NRTI, NTRTI, and NNRTI. Now, in the national program, we have zidovudin, lamivudin, abacavir as NRTI. Stebudin is no more available; it is phased out, and the only NTRTI is tenofovir. And NNRTI available under the guideline are efavirenz and nevirapine, but these are also been phased out gradually. Now, if the virus escapes this and enters into the nucleus of the cell, then it gets integrated with the host DNA by the enzyme integrase. Now, if we can prevent this integration by preventing the integrase enzyme, then the further progression of the disease will be prevented, life cycle of the HIV will be prevented, and the drugs developed were raltegravir and dolutegravir. Under the national program, we have dolutegravir. Now, once this integration is complete, then mRNA, messenger RNA, acts on this and a long chain of viral RNA is produced, which is cleaved by the protease into proviral RNAs into small segments, which have been assembled and gradually buds out of the cells to infect other cells, other healthy cells. And this reverse transcription and release of virons comes out in the order of millions to billions in a day. So you can imagine the level of infection, the speed of infection with which HIV attacks the human body. Now, under the national program, the protease inhibitor that we have are atazanavir, ritonavir, lopinavir, and darunavir. Let us now go to the same drug classes that are available under the national program in a tabular form. So under the non-nucleoside reverse transcripted inhibitor, we have zirobudin, lemibudin, abacavir, we said earlier. Then anti-RTI is TAF and TDF. TDF is available under the program, but TAF is available in the market, not in the program. Now, fusion inhibitor and fibrilator not available. CCR5 entry inhibitor is also not available under the program. And in the NNRTI, we have nevirapine and efavirenz, which are also been phased out gradually. And integrase inhibitor, we have dolutegravir and raltegravir. And the protease inhibitor, as we discussed earlier, it is ritonavir, lopinavir, atazanavir, darunavir. And there are some experimental drugs like post-attachment maturation inhibitor, which are also not available under the national program. Now, once we have discussed about the different types of antiretroviral that are available under the national program, let us now discuss about the recommended first-line ART by NACO. So any PLHA weighing more than 20 kg and more than 6 years of age should receive dolutegravir-based ART. And we are providing so since July 2020. The basic principle of first-line ART, we all know that adult and adolescent patient is a triple drug combination of two different classes of ARV. So two NRTI and one, earlier it was one NNRTI, but now it is DTG wherever possible. The first-line ART essentially comprises of NRTI backbone, preferably non-thymidine, that is tenofovir plus lemibudin, and one INSTI, preferably DTG. So for patients weighing more than 30 kg and more than 10 kg, more than 10 years, the preferred ART regimen under the national guideline is TLD. Tenofovir 300 milligram, lemibudin 300 milligram, and dolutegravir 50 milligram as a fixed drug combination, that is a single pill to be swallowed once a day at a fixed time. So it can be taken in the morning, afternoon, or night, but the timing should be fixed every day. That is, every 24 hours, the patient should swallow a medicine pill. Now, if we put a patient on ART, what are the different kinds of monitoring that we need to do? That at every visit, we are going to measure the body weight, height or length of the children, then treatment adherence, then WHO clinical staging, and 4 symptom screening of TB, and screening for NCD, that is non-communicable diseases like diabetes, hypertension, and mental health every 6 months, or as per symptom. And then laboratory evaluation every 6 months, or depending on the sign and symptoms of the patient, we can do it early or later, early also. Now, CD4 count every 6 months, and viral load at 6 months initially, then after 12 months, and thereafter annually once for first-line ART, but for second-line and third-line ART, the viral load has to be done every 6 months. Now, once we start, once the viral load is routinely done under the national program, we can stop CD4 if the viral load is more than viral load is less than 1,000, that is suppressed viral load, and the CD4 is more than 350 cells per cubic millimeter, then we can stop CD4 monitoring. However, whenever the patient fails, the SMO or MO can restart the CD4 monitoring, or whenever it is necessary, felt necessary by the treating physician, CD4 can be done. Now, once a patient is put on antiretroviral therapy, what we expect? We expect that there will be some virological response whereby the viral load will go down below 1,000, or patient will become virally suppressed, and with the suppression of viral load, the immunity will be reinforced, And with the increasing immunological response to ART, the patient will also feel better and his general well-being will be ensured, and the patient will also gain in weight and will lead a opportunistic infection-free life. Now, what is treatment failure in adult and adolescent, and when to switch and what to switch? So what are the signs and symptoms where from we can guess that the patient is probably developing treatment failure? Are clinically it is new OIs, occurrence, recurrence, or new OI, and clinical events after 6 months of ART, then we can suspect that probably the patient is developing failure. And to guess based on the clinical picture, that we need to differentiate it from the IRIS. Then if there is progressive decline of CD4 count or stationary CD4 count, then we can suspect probably the patient is developing treatment failure. And if the viral load become unsuppressed, then let us try to define what is viral failure in terms of virological load and the immunological failure and clinical failure. The virological failure, we all know, when the viral load goes beyond 1000 copies per ml after 6 months of ART with good adherence, that is more than 95% in each of the preceding 3 months. And immunological failure, the CD4 count of 250 cells following clinical failure, or if there is persistent CD4 cells persistently below 1000 cells per cubic millimeter, then we consider it to be as indicating as immunological failure. However, there are certain experts who considers that CD4 count of below 50 after 12 months of ART to be more appropriate. But in the national guideline, we follow less than 100 cells after 6 months of ART. And clinical failure, as we discussed earlier, new or recurrent clinical events indicating severe immunodeficiency, say for example, stage 4, stage 3 conditions, WHO conditions, even after 6 months of effective treatment, whenever the adherence is more than 95%. Here we need to remember that these clinical conditions needs to be differentiated from IRIS, and there are certain WHO stage 4 conditions like lymph node TB, uncomplicated pleural TB, esophageal candidiasis, recurrent bacterial pneumonia may not indicate treatment failure, while certain WHO clinical stage 3 conditions like pulmonary TB, severe bacterial infections may indicate treatment failure. Now, before we go into the detail of treatment failure and what to switch, what not to switch, let us see the relationship between the viral load, the CD4 count, and clinical status. It is important because many a times when so here we see that viral load is the first entity to start rising whenever a patient fails in a particular treatment. And after a significant lapse of time, the CD4 starts decreasing. And by the time the patient developed deteriorating clinical symptoms, the viral load, increase in viral load becomes almost plateaued. So it is important in our clinical practice because whenever we detect a patient as having unsuppressed viral load, the patient is expected to be on good health because he has just started to fail virologically. So his clinical condition CD4 status will be high. So the patient may not agree to come frequently for enhanced adherence counseling or repeat viral load or CD4 count monitoring and other laboratory investigations. So here we need to make the patient aware about this phenomena. That is, viral load is the first entity. If we do not take some corrective measures and put you on second line ART if required, then ultimately you are going to develop clinical failure when there will be severe form of OIs, and your health condition will deteriorate like anything. And this may take up to 1 to 2 years time after viral load unsuppression. Now, as we already discussed, that PLHIV on first-line ART, the viral load needs to be done first at 6 months after initiation of ART, and then 12 months, and thereafter annually. For second line and third line, it has to be done every 6 months. And for pregnant lady, it has to be done within 32 to 36 weeks of gestation. Now, how to confirm a treatment failure? We know any viral load more than equal to 1,000 copies per ml after 6 months of ART with more than 95% of treatment adherence for each of the last 3 months, we say it is a confirmed viral failure. Currently, under the national program, viral load for HIV-1 is available. So for HIV-2 infection, we need to monitor CD4 and clinically. So once a patient is tested for viral load, there is a possibility the patient will either have suppressed viral load less than 1,000 copies per ml, when we will advise the patient to continue the same ART regimen and to monitor routinely as per the national guideline. Now, if the viral load is found to be 1,000 copies or more, then we need to look at the adherence. If it is not adequate, we need to go for enhanced adherence counseling for 3 months. If after increasing adherence more than 95% in each of the month, we test the patient again, repeat the viral test again. And if the viral load is less than 1,000, we again continue the same treatment, same ART regimen, and monitor the patient as per the national guideline. But if the viral load is more than or equal to 1,000 copies per ml, then we refer the patient. And today's referral to SASEPs are the e-referral for further evaluation. That is, the patient need not have to visit to SASEP at COE or select ART Plus Center. Over the email, we'll be sharing all the documents of the patient, and the SASEP will decide based on the documents. Sometimes they may need to talk to the patient, in which case the patient may be requested to come to the ART center at a particular fixed time. Now, factors to be assessed before confirming treatment failure, as we said, the treatment adherence. So a detailed assessment of adherence needs to be made for obvious reason, as we discussed earlier. Now, drug-drug interaction. There can be a patient of HIV can have different types of medications like ATT, ART, then mood stabilizer, or say antiepileptics. So some of the drug-drug interaction may also cause treatment failure. And certain OIs and occult malignancies may lead to decline in CD4 count momentarily, which reverts back to normal after the treatment of those conditions. So we need to look at these three important aspects of treatment failure before calling a patient as failing on a particular treatment. So compared to clinical and or immunological monitoring, viral load monitoring provides an early and more accurate indication of treatment failure. And identifying the cause of failure is important before deciding to modify or switch the ART regimen. And before switching, detailed investigation into an ART adherence to be made and assess drug-drug interaction, which might intervene with ART activity before taking a decision on switch. So these are repetition only to show us that these are very important aspect before switching a patient to second line or third line ART. Now, management of PLHIV with unsuppressed viral load. When VL is available, the PLHIV, if found unsuppressed, then the patient list to be generated every day on daily basis from the IMS, and the list to be shared with the counselor, who will provide services under package C and telephonically to follow the PLHIV with unsuppressed vial and call them back to ART center. Counselors should provide intense support to improve treatment adherence. A minimum of 3 sessions, either at a gap of 15 days or 1 month, are recommended for step-up adherence counseling. It is preferred that all counseling sessions are taken by the same counselor for consistency, continuity, and proper documentation of issues that were resolved. This session should be conducted when the patient visits the ART center to collect his or her pills. Then those PLHIV who are on MMD, say for example on 3 months dispensation, then 3 sessions of step-up counseling can be provided telephonically with proper documentation in the step-up counseling form. During step-up counseling, HIV testing of spouse or partner and children should be facilitated or ensured. And repeat viral load testing to be done only when the adherence for each of the 3 months is more than 95%. Then we should go for repeat viral load. And during that period, we should also go for appropriate baseline laboratory investigations, which will be required, the result of which will be required during switch of the patient to second or third line ART. But non-availability of this laboratory investigation should not delay the SASAP referral. PLHIB who are recommended for change in regimen by SASAP should be switched to new regimen as soon as possible. And there are certain guidelines in relation to the time of referral and time of recommendation. So as per the national guideline, the VL count, the moment we know that the patient is failing, has unsuppressed viral load of more than 1000 copies per ml, then the ART center should refer the case within 2 days of receiving the unsuppressed viral report. And the SASAP in turn will have to give its recommendation within 1 week of receiving the referral. So in ESC, what are the different areas that we stress upon during enhanced adherence counseling? In the first session, we first assess the adherence and explain the viral load result, and assess the patient's knowledge regarding ART adherence and viral load, and assess the support system, that is caregiver. It is particularly important in cases of special people with mental retardation and all, and in children, and identify barriers to optimal adherence, that is side effects, depression, addiction, work timing, mental health issues, stigma, etc. Then push patients' motivations to stay healthy and alive. Discuss with the patient and develop an adherence plan which addresses the identified issues. And lastly, to remind the patient about the next ART appointments. In the session 2, we assess adherence since the last visit, and we appreciate the patient if patient has maintained good adherence, more than 95%. And we also review the strategies that were developed based on the barriers identified. And if there is any need of modification of plan, then plan of adherence, then we need to discuss and modify the adherence plan. And then remind the patient for the next due date for viral repeat test. Then session 3. In the third session, also we assess adherence since last visit, and we appreciate the patient if there is increase in adherence, and review if strategies accepted in the previous session were implemented or not, and modify the adherence plan to tackle any other new obstacles. If adherence is not adequate, plan further sessions with the patient so that there are 3 months of good adherence before going for the repeat viral load test. And then we remind the patient about the next date for viral load repeat test. So plan of next VL, if adherence is more than 95%, in the last 3 months, we repeat the viral load test. If adherence is not adequate, we plan further sessions of ESC with the patient before repeating the viral load test. Now, based on the viral load result, if it is less than 1000 copies, we appreciate the patient during scheduled visit and advise to continue the same ART regimen till the next VL test. And if the viral load is more than 1000 copies, more than equal to 1000 copies per ml, then e-referral is done to SASAP within 2 days of receiving such a unsuppressed viral load. And SASAP in return share its recommendation with the ART center within 1 week of receiving the referral. And the patient should be informed to come back to ART for the new regimen. Until then, the patient should continue the previous regimen, whatever was failed earlier. And once the patient reaches the ART center, the new regimen is switched based on his preparedness to receive the second line or third line ART. Now, steps for referral of SASAP. We know that nowadays we refer the patient over email. There is all the documents, that is complete ART history, WHO clinical stage, treatment adherence detail, and the serial CD4 count, viral load test result, and the latest investigation result, other treatment details of the patient, photos of visible signs of ARV drug toxicity, say for example, drug rash with zirconium, and other clinical records, that is discharge summary or any other relevant hospital records to be sent over mail to the COE or ART Plus center. At the SASAP, at the ART Plus Center or the COE, SASAP coordinator or the data manager shall download the patient information and prepare SASAP meeting format for review during the SASAP meeting. And in case of teleconsultation is conducted, referring ART center should be informed in advance about the date and time of SASAP to call the patient. Now, SASAP will review the document in absence of the patient and make recommendations in the SASAP meeting format. SASAP coordinator will share the recommendation of the SASAP with the referring ART center in RRF. Then referring ART center should confirm the action that were taken based on the SASAP recommendation in the RRF. That is request and reply format. Now let us discuss about treatment failure to first line ART. So before we say discuss about failure to first line, second line, and third line ART, let us know what is first line ART. For any PLHIV who is not on ART, that is a ART naive patient, any ART regimen that is prescribed for the patient is called as the first line ART for that particular patient. And second line ART is the ART, the subsequent ART regimen that are used in sequence immediately after the patient fails in the first line therapy. Now, in third line, ARTs are those ART regimen that are subsequently used in sequence immediately after the patient fails to second line ART. So before we go into this failure, ART failure, and we need to clarify two concepts like substitution and switch. Substitution is usually a replacement of single ARV because of drug-drug interaction or for programmatic policy or due to toxicities. And for switch, the entire regimen is changed to a new regimen, which is called as switch. And for any substitution after 6 months of ART, viral load should be done to know whether a single substitution of a single molecule is enough, if the enough or the patient needs to be checked for treatment failure. That is, if the viral load is less than 1,000 copies, then a single substitution of molecule might do. But if the viral load is more than 1,000, then we need to refer the patient to SASAP for second line, for switching to second line ART. Now, when to suspect, we have already seen that if the viral load is more than just around 1,000 copies per ml or gradually increasing viral load, then static or declining trend of CD4 counts and new clinical manifestations like symptoms and or signs or worsening of existing condition. Now, after reviewing the case, the SASAP can recommend switch to prescribe second line or third line ART, or regimen change is not required, continue current ART, reinforce adherence and re-evaluate or evaluate for the HIV-2. Now, steps in initiating second line ART. So step 1, define treatment failure. So it is done by the virological report if it is more than equal to 1,000 copies per ml with a good adherence. With a good adherence of more than 95% for the previous 3 months. And then in stage 2, we first decide that what are the NRTI component that we are going to use in the second line. So if the patient is on ZL in the first line, then we are going to choose TL in the second line. Now, in stage 3, we need to decide upon the second component of ART, that is whether to start INSTI or PI. If the patient was on an NRTI baseline regimen in the first line, then we are going to start INSTI, that is dolutegravir. And for patients who were on INSTI in the first line, we provide them with boosted PI, but preferably atazanavir, ritonavir in combination. And lopinavir, ritonavir is preferred over atazanavir, ritonavir in case of pregnant women, HIV-2 cases. And in stage 4, patient education and agreement on treatment plan, including follow-up and monitoring. Here, we include counseling for adherence, linkages to specialist care based on a particular case, and follow-up monitoring plan. So these are some of the mutations related with the different kinds of drug resistance for a particular ARV. These are theoretically more important, but not routinely used in clinical practice. So we are skipping it. Now, second line ART regimen for PLHIV failing on NRTI containing first line ART. So if the patient is in tenofovir or abacavir plus lamivudine with efavirenz or nevirapine, and if the hemoglobin is more than 9 gram per DL, then we are going for ZLD. So here, zidovudine 300 milligram, lamivudine 150 milligram BD, and dolutegravir 50 milligram OD. If the hemoglobin is less than 9 gram, then we are going for atazanavir, ritonavir, and dolutegravir. And we will have to maintain the NRTI backbone. That is, if the patient is on TL, we will maintain TL. If the patient is on AL, we are going to maintain AL. Now, patients who are on zidovudine, lamivudine, plus efavirenz or nevirapine, then we are going to change the patient to second line with tenofovir, lamivudine, and dolutegravir, FDC. That is a single pill to be swallowed. And in case the patient is contraindicated for tenofovir, we will start abacavir. So, for example, if there is CKD, chronic kidney conditions, or there is severe bone mineral density reduction, then we may go for abacavir. Then multi-NRTI exposed with lamivudine and efavirenz or nevirapine, then we are going for atazanavir 300 milligram, ritonavir 100 milligram, plus dolutegravir 50 milligram OD, plus existing NRTI backbone. And TDF to be maintained in all those cases where patient is found to be co-infected with hepatitis B, we need to maintain tenofovir. And in any PLHIV co-infected with TB and on rifampicin-based regimen, the dolutegravir dose to be 50 milligram twice daily to be continued till 2 weeks after the completion of anti-TB treatment. And for those with HIV-2 or HIV-1 and 2, or pregnant women, or to toxicity to atazanavir, ritonavir, we use lopinavir, ritonavir instead of atazanavir, ritonavir. And in case the patient is contraindicated for TL as a backbone, then we can go for ZL or AL also. Now, second line ART regimen for PLHIV failing on PI containing first line ART. That is abacavir or tenofovir plus lamivudine with atazanavir or ritonavir, or lopinavir with ritonavir. If the hemoglobin is more than 9 gram per DL, then we put the patient on ZL plus dolutegravir OD. If the hemoglobin is less than 9 gram per DL, or past history of zidovudine-induced severe anemia, then we go for darunavir 600 milligram BD plus ritonavir 100 milligram BD with dolutegravir 50 milligram OD. And the NRTI backbone has to be continued. If the patient is co-infected with hepatitis B, then we need to continue tenofovir. Then zidovudine, lamivudine, atazanavir, ritonavir, or zidovudine, lamivudine, lopinavir, ritonavir. The choice the choice of second line should be tenofovir, lamivudine plus dolutegravir. If the patient is contraindicated for tenofovir, say for example the patient is having CKD, then we are going for abacavir, lamivudine plus dolutegravir. And if the patient is multi-NRTI exposed with lamivudine and atazanavir or ritonavir, or lopinavir or ritonavir, then darunavir 600 milligram BD, ritonavir 100 milligram BD, and dolutegravir 50 milligram OD with existing NRTI backbone, and TDF to be maintained if the patient is co-infected with hepatitis B. And for HIV-2, HIV-1 and 2 infection, and pregnant woman and toxicity to ATVR, we are going to use LPVR instead of ATVR. Now, second line ART regimen for PLHIV failing on DTG-based first line ART. So DTG-based, that is tenofovir, abacavir with lamivudine plus dolutegravir. Tenofovir or abacavir with lamivudine and dolutegravir. If hemoglobin is more than 9 gram per DL, we are starting ZL BD plus ATVR OD. If hemoglobin is less than 9 gram per DL, then we are going to start DTG 50 milligram BD plus atazanavir, ritonavir 100 milligram OD. 300 plus 100 milligram OD with the existing NRTI backbone. Now, zidovudine, lamivudine, and dolutegravir, then we are going to start. If the patient is on zidovudine, lamivudine, and dolutegravir in the first line, we are going to start tenofovir, lamivudine, OD, and atazanavir, ritonavir, OD. And for pregnant women, HIV-2, HIV-1 and 2, instead of atazanavir, ritonavir, we are going to start lopinavir, ritonavir. Now, here we need to remember that any PLHIV co-infected with TB and on rifampicin-based ATT regimen should receive BD dose of dolutegravir until 2 weeks after completion of NTTB treatment and subsequently OD dose to be continued. Why this 2 weeks? Because the effect of rifampicin takes around 2 weeks time to wash out of the body. So we need to continue BD dose till 2 weeks after completion of ATT. Any PLHIV co-infected with hepatitis B will receive tenofovir lamivudine if not already receiving entecavir. And for those with hepatitis HIV-2 or HIV-1 and 2 infection or pregnant lady or who has suffered toxicity to atazanavir ritonavir, we use lopinavir ritonavir instead of atazanavir ritonavir. Now let us discuss about second line ART failure and third line ART. So all patients on second line ART need to undergo viral load testing every 6 months that we already have discussed earlier. Now the viral load algorithm shall be followed, the same one, that is if the viral load is suppressed, then we need to continue, we have seen earlier, to be followed before after receiving the viral load test result. Patients with unsuppressed viral load should undergo enhanced adherence counseling. Once optimum adherence is achieved for 3 consecutive months, repeat viral load test to be done. So it is similar to the first line ART failure. Now, workup. So refer all cases with suspected second line ART, second line failure to Centers of Excellence, COE or ART plus center if adherence is good and there is no major OI. Poor adherence or major OI identified, then we need to go for step-up adherence counseling and close monitoring. If no improvement is seen, even after 3 months of good adherence, then we need to refer the case to COE or ART plus center. And prescription of third-line ART regimen can only be prescribed by SASAP at COE and selected ART plus center. After the SASAP has reviewed the patient and prescribed third-line ART, initiation and the follow-up to be done and dispensation of ART to be done by the parent ART center. Unlike previously when we used to refer the case to the COE for 6 months for ART initiation and follow-up, nowadays we can start the patient on ART in the parent ART center and can follow up with regular feedback to the SASAP. Now, what are the different third-line regimen we have for a particular patient? Now, a patient on 2 NRTI and 1 NRTI based first-line regimen and in the first line and failing to which they started on PI-based regimen, then the recommended third-line regimen would be darunavir, ritonavir, BD plus dolutegravir OD, and existing NRTI backbone to be continued and tenofovir to be maintained if the patient is co-infected with hepatitis B. Patients who were on 2 NRTI plus 1 NRTI as first line and failing on second line with INSTI-based regimen, that is either zidovudine, stebudine, tenofovir, abacavir plus lamivudine with dolutegravir in the second line, and they have failed the second line, then the recommended third line would be darunavir, ritonavir BD plus dolutegravir 50 mg BD plus existing NRTI backbone. Now, patients who were on first-line regimen with 2 NRTI plus PI and who failed on the INSTI-based second line, the recommended third-line regimen would be dolutegravir 50 mg BD and darunavir, ritonavir BD, and existing NRTI backbone to be continued. Patient who were taking 2 NRTI plus PI as the first line and failed on it and are on an NRTI baseline, NRTI based second line regimen. This was the case when we did not have dolutegravir in the program. We used to shift those patients on first line ART with PI based regimen. Once they fail, we used to shift them on an NRTI based regimen. So a few cases we might have to decide now. We'll find this kind of few cases, not more, after the initiation of dolutegravir. So any patients who had 2 NRTI and plus 1 PI in the first line has failed and then received an NRTI regimen in the second line, their third line drug would be darunavir, ritonavir BD plus dolutegravir 50 mg OD plus existing NRTI backbone. Here it is important to notice that the dolutegravir is 50 mg because the patient never received dolutegravir in his whole life. So dolutegravir dose is 50 mg OD. But in all previous cases, the patients were exposed to dolutegravir for which their doses in the third line is 50 mg BD. Now, patients who had 2 NRTI plus PIS first line and failed on it and are on darunavir, ritonavir, BD dose second line regimen. For them, we have DTG 50 milligram OD plus darunavir, ritonavir, BD with existing NRTI backbone. And for all PLHIV with comorbid hepatitis B, tenofovir need to be continued. And in case of any contraindication to tenofovir, such patients to be referred to the National Viral Hepatitis Control Program for entecavir. And for those patients without any hepatitis B and indicated for tenofovir, we need to change to other NRTI backbone. So if tenofovir is contraindicated, we are going for abacavir, AL. Now, once a patient is put on ART, what are the things that we are going to monitor and what interval? So hemoglobin or CBC at baseline, then at first month, third month, 6 months, 12 months, 18, 24, and then every 6 months. Then complete LFT at baseline, third month, 6 months, 12 months, 18 months, and then annually. Sorry, every 6 months. Then renal function test at baseline, third month, 6 months, 12 months, 18 months, then every 6 months. And fasting blood sugar at baseline, 12 months, 24 months, that is annually. And fasting lipid profile at baseline, 12 months, 24 months, thereafter annually. And viral load baseline, 6 months, 12 months, 18 months, 24 months, and every 6 months. CD4 count at baseline, 6 months, 12 months, 18 months, 24 months, and every 6 months thereafter. And timing for CD4 testing at every 6 months till a CD4 count is more than 350 cells per cubic millimeter. And if the plasma viral load is less than 1000 copies per ml, then we can stop CD4 monitoring. And it can be restarted by the treating physician if the patient has viral load of more than 1000 copies per ml, or if the CD4 cell count goes down below 350. If the plasma viral load goes up to 1000 or more. And even if the plasma viral load is suppressed, for clinical reasons, the treating physician can restart CD4 monitoring. HIV-TB in second line or third line ART patients. TB, as we know, is the most common Y and is one of the most common cause for high morbidity and mortality in PLHIV. So we need to treat PLHIV who are suffering from tuberculosis adequately, but we need to take into consideration drug-drug interaction between ART and ATT. So rifampicin, as we all know, is alters the metabolism of PI and reduces effectiveness of standard doses of PI because it is a strong hepatic enzyme inducer. So in case we need to treat patient on PI with rifampicin, we need to replace rifampicin with rifabutin containing ATT in the presence of PI without compromising the efficacy of ART or anti-TB treatment. But nowadays, probably in many of the cases, many of the places, rifabutin is not available. In such a case, we need to modify the ART regimen if we want to continue with the rifampicin-based regimen. Dose of rifabutin, if we use rifabutin, the dose should be 150 milligram once a day for all PLHIV more than 30 kg for the entire period of co-administration of anti-TB and the second line ART. Second or third line ART regimen containing PI. Whenever rifabutin is prescribed, instead of usual FDC packs, individual anti-TB drugs to be provided, and these are not available in the ART center. These are available in the DTCs. Some of the common side effects of rifabutin are orange-brown discoloration, which is also common with the rifampicin, we know. Then when the patient experiences chest pain, muscle ache, severe headache, fatigue, sore throat, flu-like symptoms, vision changes, unusual bruising or bleeding, nausea or vomiting, and or yellowing of the skin or eyes, further evaluations are required. The initiation of patients who are already on ATT and needs to be initiated on PIB second line or third line ART regimen, we substitute rifampicin with rifabutin for 2 weeks prior to initiation of second line ART. This should be done to allow hepatic metabolism induced by rifampicin to normalize prior to initiation of PI-containing regimen. Initiation of anti-TB treatment in patients already on PI-based ART, we substitute rifabutin for rifampicin within the prescribed anti-TB regimen from the start of TB treatment. Second or third line ART regimen containing integrase inhibitor, we can continue rifampicin safely. Just we need to increase the dose of DTG, dolutegravir, to 50 milligram twice a day, and to be continued till 2 weeks after completion of rifampicin-based ATT regimen. Now, management of side effect related to second and third line ART regimen. So tenofovir, we know it is usually well tolerated. The only problem is with the minor weakness, lack of energy, headache, diarrhea, nausea, vomiting, and flatulence. And these are usually settles down gradually as the patient go on taking the medicine, and symptomatic management can be done. For more serious side effects like kidney failure or pancreatitis, we need to change tenofovir. And tenofovir can also reduce bone mineral density, where calcium supplementation need to be provided. And for dolutegravir, usually well tolerated, but some of the reactions, some of the adverse effects like insomnia, headache, depression, suicidal ideation, though rare, and weight gain, hepatotoxicity, and potential for neural tube defect in infant born to individual who received DTG-based regimen and during the time of conception is it was thought to be very higher than the general population, but with the accumulating evidences, it has been seen that the incidence of neural tube defect is no more than the other ART regimen. So, and rarely a patient can develop hypersensitivity reaction, including rash, constitutional symptom, and organ dysfunction. But all these symptoms are less in frequency compared to raltegravir. And symptomatic management is done for minor side effects, and informed concerns to be taken before the initiation of DTG-based regimen in pregnant women for the risk of neural tube defects. Now, for atazanavir, we know for all PI, used to produce metabolic side effect like hyperglycemia, fat maldistribution, hyperlipidemia, but these are more common with ritonavir than to atazanavir. Now, increased bleeding episodes in hemophiliacs. The unique side effects of atazanavir include indirect hyperbilirubinemia. That is yellowish discoloration of the skin, and sometimes it can also give rise to skin rash, nephrolithiasis, and cholelithiasis. This patient needs to be counseled before the initiation of atazanavir-based ART that they can develop jaundice, which are usually not harmful. And for patients who develop severe skin rash and all, they are to be referred to respective specialty department. And for management of atazanavir-induced unconjugated hyperbilirubinemia, we will see it after in the later slides. And atazanavir, ritonavir also interact with the antacids and ACE2 blockers. So we'll have to take 2 hours before or 1 hour after taking antacids or any buffered medication. So lopinavir boosted ritonavir side effects are similar to the atazanavir ritonavir, but here the abdominal pain GI side effects are more pronounced and includes abdominal pain, abnormal stools or bowel movements, diarrhea, feeling weak, tired, headache, and nausea. And symptomatic management usually corrects these minor side effects. Patient can taking lopinavir ritonavir should be monitored for possible liver problems like liver problems, and supportive counseling and use of other drugs to manage gastrointestinal effects should be done. These symptoms improve after a few weeks. Now, people who have liver disease such as hepatitis B or hepatitis C may experience a worsening of their liver condition. A small number of patients have experienced severe liver problem, and we need to monitor LFTs, lipid profile, and blood sugar regularly. And lemibutine, it is one of the safest antiretroviral drugs. And few side effects in the form of cough, diarrhea, dizziness, headache, loss of appetite, mild stomach cramps or pain usually goes off if the patient continues the treatment with supportive symptomatic management of these side effects. Now, more serious side effect in the form of burning, tingling, or pain in the hands, arms, feet, that is the neuropathy or legs, chills, ear, nose, or throat problems, fever, muscle aches, nausea, pale skin, severe stomach pain, skin rash are very rarely seen with lamivudine, though it can give rise to rashes. We have seen many cases. Then darunavir, skin rash. Darunavir has some sulfonamide moiety in it. However, the incidence and severity of rash are similar in those with or without a sulfonamide allergy. That is Stephen-Johnson syndrome, toxic epidermal necrolysis, acute generalized exanthematous pustulosis, and erythema multiforme have also been reported. For minor thing, we symptomatic management of minor side effect and supportive counseling and use of other drugs to manage gastrointestinal effects should be done. These symptoms improve after a few weeks of continued treatment. Now, other adverse effects like hepatotoxicity, gastrointestinal intolerance, headache, hyperlipidemia, severe transaminase elevation, hyperglycemia, and fat maldistribution is possible. So we need to monitor LFT, lipid profile, and blood sugar regularly, just like atazanavir, ritonavir. Now, atazanavir-induced unconjugated hyperbilirubinemia with the prescribed dose of 300 milligram atazanavir and 100 milligram ritonavir once a day. Unconjugated hyperbilirubinemia tend to occur within 1 to 8 months of initiation of ATVR. An isolated elevation in total bilirubin should be confirmed as predominantly unconjugated by testing the indirect fraction of bilirubin. Further investigation is required only when the conjugated bilirubin, if there is any conjugated hyperbilirubinemia along with instead of unconjugated, and if there is changes in hepatic aminotransferases along with the unconjugated hyperbilirubinemia, then only we need to do some further investigations. Now, with a little bit increase of unconjugated hyperbilirubinemia, we need not have to change ATVR. We can reassure the patient and that these are harmless and they can continue the medicine. An alternative regimen, if the patient doesn't want to take ATVR, then of course we need to respect his decision and we need to change the regimen, but we need to counsel before changing such a regimen. This produces only cosmetic problem in these patients and it is harmless. Now, if the patient develop an unacceptable level of jaundice, that is grade 3, that is 5 to 10 times the upper limit of bilirubin, or 4 times, that is more than 10 times upper limit of normal of serum ALT AST, we need to change the regimen with an alternative regimen. In case of hepatic insufficiency, dose adjustment is recommended. In case of Child-Pugh score A, we can we can continue the ATVR, but in case of Child-Pugh B and C, we should stop ATVR. And it should be based on second-line patients with Child-Pugh B. It should not be used, as I said. Now, atazanavir-induced unconjugated hyperbilirubinemia. In presence of this, we need to do Child-Pugh score, and it is based on the there are different components. One is encephalopathy, ascites, albumin, bilirubin, then prothrombin time, INR. So these are difficult to remember. We can keep it on table, our table, and then for each case, we need to refer to this table. Now, the encephalitic grade, we know it is grade 1, 2, 3, and 4. Mild confusion, no confusion is a grade 1. Anxiety, restlessness, fine tremor can be there. Then in grade 2, drowsiness, disorientation, hysteresis, or hepatic flap would be there. In grade 3, somnolent but arousable, marked confusion, incomprehensible speech, incontinence, and hyperventilation. And in grade 4, coma, decerebrate posturing, flaccidity. Now, based on this, we can classify the patient into class A, B, and C. If it is 6 or less, it is class A. So up to 6, score 6, we can continue atazanavir, ritonavir. And in case of score 7 and more, we should not continue ATVR in case of hepatic diseases. Now, dolutegravir. Some of the drug-drug interaction of dolutegravir is there and to the cation-containing antacids, then iron and calcium. So we need to administer DTG 2 hours before the such kind of cations or 6 hours after such kind of cation ingestion. Now, in case of rifampicin, we need to increase the dose of DTG, as we have seen earlier, to twice a day instead of once, and to be continued 2 weeks after the cessation of ATT. Now, with carbamazepine also, we need to provide DTG 50 milligram twice daily. And for metformin, co-administration with DTG, we need to limit the dose of metformin to 1,000 milligram per day because DTG increases the availability of metformin. Now, as a class, all protease inhibitor, we need to avoid estomazole, cisapride, fluticasone, indinavir, lombastatin, simvastatin, midazolam, and tarfenidine. And rifampicin decreases concentration of boosted PI and should not be used concomitantly. And atorvastatin, increased concentration of atorvastatin is possible, and to administer the lowest effective atorvastatin dose while monitoring for adverse events. Now, antiretroviral drug atazanavir, we have seen the drug-drug interaction. We know that it interacts with the H2 blocker and antacids. So we need to administer atazanavir 2 hours before or 1 hour after the H2 receptor antagonist. But patients find it difficult to remember this 2 hours before, 1 hour after. So we can go for telling the patient to take it either 2 hours before or 2 hours after. And the dose of H2 antagonist should not exceed the dose equivalent to famotidine 40 milligram BID in ART naive patients or 20 milligram twice daily in ART experienced patient. Now, proton pumps are not recommended in ATVR, but we can give it with a gap of 12 hours between atazanavir, ritonavir, and the PPI. Now, in presence of buprenorphine, which is used in the OST center for people on opioid who are having opioid dependence, we prescribe buprenorphine, and there is no, even though a little bit of drug interaction there, but there is no clinically relevant interactions, and we can continue buprenorphine along with the standard ART without any problem. But for methadone, there can be withdrawal might be precipitated in people who are taking methadone along with ART. So we need to, particularly atazanavir, ritonavir, and we might have to provide additional dose of methadone. Now, these are the drug interactions of second line and third line. Now, this was my job. So let's see what questions participants are going to ask.
Thank you so much, sir. Any questions from the participants? You can type in the chat box or you can unmute your mic. Kiran sir, can you please give mic access to all?
Given already.
Yes, thank you. Any questions from the participants? So I don't think there are any questions. Can we please quickly run the feedback form, Kiran sir? So you can stop sharing the screen now.
Okay.
Thank you. The feedback poll is now visible on your screen. Participants are requested to please answer the feedback poll. There are 4 questions in all. Please answer all the 4 questions. Kiran sir, we can end the feedback poll. Thank you, Rajeeb sir, for facilitating this session. Thank you to all the participants for patient listening. So can we conclude the session now?
Yes, please. Thank you all.
Thank you, sir.